700.
Several.
6, 7?
1,000.
Okay, that's more people that listen to me than what I have at home. So that's great. 14, that's great. Okay, we'll get started. My name is Austin Fair, co-owner of Fenix Physical Therapy. And today we got some Con Ed for you. We're going to go over upper cross and lower cross syndrome and some lifting techniques. So we're just going to jump right into it so we don't waste any time. Let's go to the next slide. Okay, so there's going to be three main things that we're going to go over today. We want to teach you how to mostly just take care of your body. We understand that you guys need a 25-year career and you're at different phases in that career. And so we want to give you some tools to help you assess if there's could be a potential injury. We want to give you a little bit of treatment on how to address it, and then also go over some lifting techniques that are going to help you take care of your body and lift, and inevitably lift with more power and lift from the ground better than what you had before. Like I said, I'll give you a little bit of background on us. Brad and I both went to ASU at different times. We were about a year apart, different campuses. We both went to NAU Physical Therapy program, and in 2017, I started Fenix Physical Therapy as a cash pay practice. Brad and I partnered in 2020, and Brad had a lot of connections with the fire department. I have a lot of family members who are part of the fire services, and we created Fenix Physical Therapy to focus primarily on first responders, firefighters, law enforcement, to help improve your quality of life, your longevity, and performance level. So we'll hit that next slide. And here's just something that I'll take 30 seconds to focus on this. The goal for us and for you guys is to maximize your performance. We want you to maximize the longevity of your career, and we want you to also have a really high quality of life. Sometimes they can coexist, but other times the way that we move our bodies and the way that we treat our bodies, they cannot all three coexist at the same time. We might sacrifice longevity of our career or of a shift so we can have a high level of performance. Or we might focus on the longevity of our career, but we might lose a little bit of quality of life. And so for us, our goal is to help maximize all three of those things for you guys. And that's the lens in which we'll look through as we go through this training today. Hit that next one. Okay, so right here, if you were in person, I'd ask you to raise your hand if you've ever had an injury before, like lower back, shoulder, hip, knee, ankle. We got some hands going up in the background. Like there are people here who deal with a lot of injuries, and I want you guys to know that you're not alone. Let's get this next slide. So let me read these stats. Okay, so 63% of all EMS have had either a lower back injury, a mid back injury, or a shoulder injury. So more than half. And then 70%, nearly 3/4, have had an overuse injury. So all of these injuries that happen, they're to the spine and upper extremity, but also they happen because they're being overused. We're spending more than what we have in the bank account physically. And that could be due to a couple reasons. A gee whiz fact is that the second leading cause of injuries to EMS workers is violence. So be careful with who you interact with. The next part is who is at risk. The demographics of people who get injured is 41% of the people age 25 to 34 are the ones who get injured. So that's the primary group that gets injured. The second highest group, age group, is 35 to 44. I think once you're a little bit older, you figure out what your limitations are, and or you're not as much the workhorse on the crew as what some of the younger guys are. So they're a little bit lower risk for injury, but injury risk is still high. Final stat I'll share with you is that 1 in 4 EMS workers are forced into early retirement because of an injury that happened. And so we want to make sure that you guys can take your career as long as you want, and you're not limited physically. You're not forced out of a career because of something that happened with your body. This next part that we're going to go into, we're going to go through a little bit of anatomy and how the body moves and postures and positions that put us at risk for further injury. Brad, why don't you come up here and take over that?
Absolutely. Okay, so if we can keep that image on the screen for 1 second. If you see on the top left, we call this bruh posture. For anyone who knows what a bruh is, it's different than a bro. A bruh is exactly what you see in that image. So anatomically, what we're going to point out here is that in American society, we have a high prevalence of succumbing to the influence of gravity. And so what will happen, oh, Chief Vilt just corrected his posture there, just looking at the picture. Nice job, Chief. What's going to happen is the path of least resistance. I tell people, I wish we didn't focus so much on getting our steps per day. I wish we had something that could attach to our bodies that showed us how much we sit per day. And if you look at the effects of sitting, there's a phrase out there that says sitting is the new smoking. The mechanical effects of prolonged sitting is that the shoulders are going to round forward. And those of you, we're going to talk a little bit more medical. Look at Caesar knows he's got to stand too. He's sitting too much. But you guys will see that the effects of posture will speak a little more medical to you, that the thorax, the T-spine, as you come forward, that's called a kyphosis, if you remember that from anatomy. And then the corresponding secondary effect is that the head comes backwards, and that's a lordosis. So Brian, would you mind joining us up here? Okay. We have a live feed now, Chief. Okay. So Brian, I'm going to be faced toward the clock here. So posture-wise, male, female, old, young, especially those who train for the physical tasks that are required of being a first responder, we tend to be a heavy press dominant population. And that press dominance creates a flexion and a pulling forward that kind of preloads us in this bruh posture. So Brian, rather than good posture, I want you to slouch a little bit. So you'll feel that this curvature here, this is a thoracic kyphosis. The secondary effect is then we need to see the world around us, and it creates that cervical lordosis. So the opposite of this posture, if you stand nice and tall, shoulder blades back and chin down, this now straightens out those curves. So this is what we refer to as a neutral spine. The issue is, if you've ever seen those pictures from National Geographic of the women that have like the 17 rings around their neck, and their neck is like 14 inches long, or if you know anything about astronauts going into space, not having gravitational load, they come back and there's massive prevalence for fracture because they don't have these mechanical loads. That's called the SAID principle. So Brian, when you live in this flexed position, your body is going to adapt just like that African woman or just like that astronaut, that this becomes the normal predisposition, right? And so what we're going to talk about today are ways that we can assess where is our mobility, not just in a front and back sagittal plane, but also how do we rotate, right? And how do we side bend? And those are the three primary movements of the spine that we're going to assess today. So this first one, this is called upper cross syndrome. Flex shoulders and an elevated chin with excessive load on both the mid-back and the neck. That's upper cross syndrome. So that's number one. All right, let's swap out. Edgar, you got next one?
Yes, sir.
Let's hit that next slide, Austin. So this next principle is called lower cross syndrome. Now, Edgar, I'm going to be faced sideways as well. Now, the pelvis of the body we say is shaped like a punch bowl. And so if the punch bowl has excessive tightness on the front from all this sitting that we've been talking about, Edgar, if we hinge here, even look at the creases in the clothing, right? As the soft tissue shortens on the front of the body, these hip flexors and quad muscles that attach at the pelvis, they become shortened. And so what happens is when Edgar stands tall, instead of the ability for the front tissues of the thigh and hip flexors to lengthen and for the punch bowl to sit flat, what happens is the punch bowl gets stuck and the punch is spilling out the front. And what happens is we then compensate with this forward flexed, and then we create a lumbar extension. So there's that other lordosis that we talked about. So excessive curvature of the low back. Now this is exaggerated. If we can show that, Caesar, if we can show that image on there one more time. So that lordosis that you see there, these are pretty, it looks dramatic, but it really isn't. When you sit on an airplane for 4, 5, 6 hours and you stand up and you're like, I think I'm 4 inches shorter, right? It's that ability to get into full extension of the hips. 9 times out of 10, it's not even available. So what we're going to talk about today is how do we assess the lower and upper cross syndrome. So this one's referred to as lower cross syndrome, when the hip flexors are tight and the pelvis is pitched forward. And then the second one, or the first one we talked about, is that upper cross syndrome. We're going to talk about how do you assess it. And then the second one is what are the correctives to make sure that these things are available. We'll get into some other slides. I just want to give a little teaser. That's good, Edgar. Thank you. We'll talk about the way that your body is designed to move. We have some slides in here in just a second. They're going to talk about how mobility and stability, that these are the foundations for a hierarchy of movement. And we'll get into that a little bit more. And then we're also going to talk about how it is that your low back and your hips, your knees and your ankles, all of them are designed for specific roles. And at any time that the role or the design of a structure is undone, it tends to have a negative ripple effect to where you start using things for something they're not designed for. 9 times out of 10, when we work with a first responder and there is some sort of irritation of a chronic expression of an injury, the injury most cases is the victim and not the culprit. So in this case, what we're going to talk about, lower cross syndrome, it is the excessive tightness of the hips that create this mechanical load to the low back and then create this pressure. So we're going to get into some of this. You want to go one more slide? Okay, here's just a more up-close view. If you guys are looking at that on the screen, you can see that this lower cross syndrome, the cross is basically connected between that top left part of the image that you see of weak abdominals. When people tell you, oh, your back hurts, you should do more abs. It's totally true, 100%. The issue is that if you look at the lower left part of the screen, the tight hip flexors, if you have excessive shortening or tightness of a hip muscle, you will never be strong enough in your core to counteract the immobility that comes from that. It'd be a tug of war between a Honda Civic and F-250. Like, you just have too much power output below the pelvis to counteract and to stabilize through the abdominals. So may it help? Yes. But achieving the proper mobility of hip flexors is going to be huge in conjunction with being strong in the core. Now, those second two on the posterior chain, if you look at the upper right, that thoracolumbar extensors, that is basically just saying your glute hamstring complex. The ability to get the low back lengthened and decompressed is one part of that. And then the second part, if you look down at that glute max activation, all of these, just imagine that punch bowl idea. We're spilling punch out the front of the bowl. And so in order to get the punch bowl level again, we need to lengthen the hip flexors, which is the bottom of the front, if you can visualize that. We need to activate the abdominals, which is the top of the front. And then glute activation is actually one of the strongest, most corrective muscle activations for preventing injuries and lifting. Specifically, what was it, 63% you said, Austin? 63% of these EMS injuries. So these are the principles of upper and lower cross syndrome. And now we're going to get into, what's our next slide? Is this one yours?
Mobility, stability, and then
do you want to go over this? You want me to go over that?
I can do it.
You want to do it? Okay.
So in this slide here, it's a representation of how our body should move. As Brad talked about a little bit ago, there's a sequence of joints that should be movable and joints that should be less movable. When we talk about mobile joints, as you see on the slide, these joints move in 3 dimensions. Like, all joints move, the majority of joints move, but the stable joints only move in 1 or 2 planes of motion. The rest of them should be movable. Now, where we get caught up in the lower cross and upper cross syndrome is the joints that should move are actually the joints that aren't moving, and the joints that should be stable are the ones that end up moving. So as you look at this slide, there's this alternating pattern of joints that are mobile and joints that are stable. Your foot needs to be stable. The next joint up, your ankle, it needs to move in 3 dimensions. The next joint up from that is the knee, and that should be stable. Next joint up, the hip, it should move in 3 dimensions, and that should be mobile. Lumbar spine, it moves, but only in 2 planes of motion. It should not move in all 3 dimensions, and so that needs to be stable. Mid-back needs to be mobile. Shoulder blade needs to be stable. Glenohumeral joint or shoulder needs to be mobile. And as you see, there's this alternating pattern of mobility and stability. And again, the issues with the development of upper cross and lower cross syndrome is if your hips become really, really stiff, your body's going to require movement when you're lifting something, when you're carrying something, or picking something up from the ground. If your hips are stiff and you can't get down to the ground, your body's going to ask your knees or your lower back take on a bigger role than what it should, and it depletes its capacity or whatever reserves you have in the bank account, and it builds up to an overuse injury. And so what we're going to do in our next slide, we're going to go through some upper cross syndrome mobility assessments. What we like to say, Brad, you can hit that next slide, is this is a good one too, just to show there can be a weak link in the mobility stability, and typically everybody has one. We just want to identify, and that's part of what we want to do. So what we like to say is we want to assess and not guess. There's so many times when you think, oh, my shoulder hurts. Well, let me just do these exercises. Let me throw stuff on a wall and see if it sticks. Rather than just doing a whole bunch of things and seeing if we get lucky, we want to be very specific in how we determine if we have upper cross syndrome or lower cross syndrome, and then we can attack it head on. We got Gabe out there? Gabe, come on in, Gabe. Okay, come take a seat here. The first thing that we're going to do is to check neck mobility. The neck should move in 3 planes of motion, and the easiest way to test this is you should be able to rotate your head all the way to the right and touch your chin to your collarbone. Is that touching there? Or we got some space? Good. Okay. All right, look straight ahead. All right, good. Turn your head straight. Now turn your head to the left and touch your chin to your collarbone. Okay. On this side a little bit, go ahead and look straight again. We want to be careful to not cheat and shrug the shoulder up to kind of meet the need or get there, just because we don't have enough flexion in our neck. So if you cannot touch your chin to your collarbone, then you're lacking mobility. And that's okay, but we want to identify, okay, does my neck have enough mobility? If you can touch your chin to your collarbone, you're in good shape. The next one.
Austin, yeah. What if somebody's asymmetrical? What if one side feels different than the other or moves different?
That's a great question. In all of these things, it's okay to be tight. It's okay to be stiff, but we don't want to be stiff on one side and movable on the other side. We like to say, if you have a big truck, it's okay to put like big tires on it. You can put mud tires on it, or you can put low profile tires on it. But you can't have big mud tires on one side and low profile tires on the other side. It's going to mess with everything. So if there's asymmetry, if you're mobile on one side and the other side is stiff, that's something that you want to look into, because that is a number 2 risk for an injury. The number 1 risk of an injury to a body part is a previous injury to that body part, and the number 2 risk is an asymmetry. So if you're doing any of these drills and you can accomplish on one side but you can't on the other, or there's a noticeable difference between left and right side when you're doing it, that's something that you want to take note of and then begin to address it. So thanks for bringing that up. Okay, the next one, we're going to do a mid-back mobility. So Gabe, scoot forward a little bit, and then what I want you to do is put your knees and your ankles together, and then put your arms across your chest. And through this movement, just make sure that your knees don't come apart. I want you to rotate your upper body to the right. Good. Now, in this assessment, what we're looking for, if this is straight ahead and this is 90 degrees here, I want to see if there's 45 or more degrees of rotation. And so you're going to need help on this one, to have somebody come stand behind you and say, okay, what type of motion do I have? And Gabe is right at 45, 50 degrees, so he's good on that one. We'll do the same thing, and we'll rotate the other way. This side, it's got a little bit more than that, a little 50, 55, 60 degrees of rotation. So that looks good too. What we're looking for, sometimes when your knees are apart, what will happen is it's really easy to shift your pelvis back, and you don't get a true reading. And so, yeah, Gabe, just kind of put your feet wider and rotate left. You might see, instead of this knee being right in front, you can see how this knee kind of shifts backwards that way. And now he's like at 70 or 80 degrees of rotation. So just to isolate the mid-back, we keep the knees and the feet together, just so we can determine that the motion is purely coming from the mid-back. So if you're at 45 degrees, or less than 45 degrees, you want to take note of that and say, okay, this is an area where that needs to be mobile, but it's behaving like it's stable. And then we'll get into some interventions on how to address that too. Okay, the last one is the lat mobility test. Go ahead and stand up for me, Gabe. Yeah, let's go here. Okay, so what I'm going to have you do, I'm going to have you bring your back up to the wall and get into like a half squat and put your lower back flat up against the wall. And if you would, I'm going to slide this dowel right here and go ahead and pin that dowel up against the wall. Okay, now put your head up against the wall. Elbows locked, hands straight, and raise your thumbs up all the way and touch the wall. And this is really good. What we're looking for is to see how tight our lats are, because lats are big, powerful muscles. Sometimes what will happen, go ahead and come back down. I put this dowel back here because I want his back flat against the wall. Sometimes if you have tight lats, what will happen is as you raise those arms up, your back's going to arch and you'll get into that lower cross type position, but it's driven by the tightness of the shoulders or the lats. And so, Gabe, if you were to pretend like your lats were tight, it would slide down and there'd be a lot of wiggle room through here. Go ahead and come back down and we'll do it again. Okay, do it one more time. One of the ways that people might cheat is they'll bend their elbows and try to touch here. So make sure that those elbows are locked. Excellent. And again, assess, is it easier on one side than the other, or is it pretty equal on both sides? Okay, come on back down. All right, thanks, Gabe. But those are the 3 tests we have. The neck mobility test, where we're rotating chin to collarbone without coming up here. We have the seated thoracic rotation test, where we want to get a minimum of 45 degrees of rotation. And then we have the lat mobility test, where you want to make sure you sit down at a 3/4 squat position and keep that back flat up against the wall and lock out your elbows and get thumbs to the wall. All right, Brad, do you want to take care of lower cross mobility stuff?
Okay. Caesar, is that image on the screen there? Okay. So we're going to walk you through those 3 are to address upper cross syndrome. We talked about the ability to kind of get out of that bra posture. All 3 of those, we'll talk about the correctives. What we love about lower cross syndrome is that the assessments we're going to do are also the correctives. So pay attention that as we take you through these measurements, these will also be the ways that you can correct it. So, Brian, you want to be our first one? So this first one is called couch stretch. And so, Brian, you're going to start with your left foot in front of the pad. You're going to clip your toe on the chair, and I'm going to have you kneel down for me. Actually, you know what? Let's do right foot in front with the left leg back. We'll see it better. Perfect. Okay, you can use this dowel for stability. Okay, so in this position, 2 major movements that we're looking at. We see that we're taking up all of the slack of the quad through a big knee bend. Can you see that? So this big knee bend here. The second movement is that we are trying to create that tall vertical pelvis, right? So when these muscle tissues on the front of his left quad are not long enough, what's going to happen is he is unable to get his pelvis underneath his knee. So the first test that we'll do here in this position is that you're going to push down on that rod. And this goes back to that first explanation we had of core activation. So the core is tight. And when you activate that core, it's going to pull the front of the pelvis up. Do you feel that? Okay. So that pelvis elevation on the front, that's correcting the lower cross posture that we're trying to prevent, right? Now the second thing we're going to do, and this is a little more spicy, is now you're going to contract your left glute.
Oh, yeah.
Okay, a little spicy, right? Yep. So this corrective right here, and it's an assessment and a corrective, we should be able to get our butt within a few inches, or our heel within a few inches of our butt, and that's measuring knee movement. And then we should be able to put our left hip in front of our left knee. Now, can you see the lower cross predisposition here? If he doesn't have enough hip mobility to get in front, what's going to happen? We're going to turn into that lumbar extension. Now we're creating lumbar, we said, is what? It's supposed to be a stable structure. The hip is supposed to be what? A mobile structure. So if we lack mobility in the hip, this is the perfect example of how we start to create a mobile structure is not doing its job, and therefore a stable structure becomes mobile. Low back pain, your lumbar spine is the victim of hip immobility. Does that make sense? Okay, so big takeaways on this one. Austin talked about these 3 different planes of movement. The first one, that glute contraction forward, that's going to lengthen. And like you said, Brian, you could feel that kind of mid-thigh, right? There's only one of your 4 quad muscles. Quad meaning 4 muscles, right? There's only one of them that crosses the knee and the hip, and it's called your rectus femoris. That's usually the primary culprit for this lower cross syndrome. It gets too tight because it crosses both of them. The second one, you guys have probably heard about psoas, the iliacus. Those are your high hip flexors. They actually attach on your lumbar spine. We can send you guys some images of that if you're interested. But basically that tightness is pulling you into that belly out, that lower cross syndrome that we showed on Edgar, right? So first plane of movement is north and south. Second plane of movement, we're going to take this dowel. You're going to put it outside this knee. The intro version, both hands on. We're now going to create some rotation. Austin talked about the planes of movement for hips and low back. This is one that we're going to start to introduce more hip rotation with the extension. So again, push down and then contract that left glute. And you feel a pretty hearty stretch there?
Yep.
Okay. Now the last variation, probably the highest intensity, is you keep your left hand on the dowel. The right hand's either going to go to your foot or to the chair. And now we're going to wind up even more. So you think about wringing out a washcloth. We're creating that torsion force. And now contract that left glute again. Pretty spicy there, right? Now, Austin has a great phrase that he uses. He says, don't stretch muscles, stretch movements. Meaning your body should be able to create certain shapes. And if it can't, is it nerve tissue? Is it ligament? Is it muscle? Is it motor control? I don't care. We just need to be able to create that appropriate mobility. And so some days you may do this, you may feel a lot of quad. Some days you may feel more hip flexor, maybe contralateral lumbar. But whatever it may be, these are the structures that are going to limit your ability to create the shape to do your job. Okay? Now the last one, I'm going to steal your dowel. I'm going to have you put your hands above your head. This is the last plane of movement, frontal plane. You're going to grab your left wrist and you're going to side bend to your right. Now we get all of this long tissue, basically from the elbow to the knee, everything's going to be lengthened. So we have tricep, we have lat, we have oblique, we have glute med, we have IT band, it's all connected, right? But now here we are creating hip extension with a side bend. These are the multiple planes kind of combination movements that we've been talking about. So these 3 movements, these are all the assessment. And what we would do is then we'd go through the opposite side. And Austin talked about contralateral asymmetry. If you're not symmetrical, you can rest there and go and stand up. If you're not symmetrical, that's okay. But to know that, and I guess a common question we had asked is, if I'm tighter on one side than I'm on the other, should I stretch that side more? And the answer is yes. We say that the teacher spends more time at the little kid's desk that needs the most help, right? Same idea. If that left hip flexor tends to be your lockup, maybe you were a swinging, throwing athlete and you have a length on the right but a shortening on the left, that would create asymmetry, right? Maybe you're a semi-pro pickleballer, or maybe you think you are. That ability to create rotation is great, but it tends to create these asymmetries in mobility. So yes, address the tightnesses or the immobilities with more resources, okay? So this first one, that's couch stretch. It's the assessment and it's the correction. Okay, Edgar, you want to be our next one? Okay.
Hey, Brad, as Edgar comes in here, do you mind if I have a clarifying, make a clarifying point?
Make it better, Austin. You can say it. I'm not good enough.
We talk about 3 planes of motion, and I just want to clarify some of the stuff that that we've said. Is typically when we stretch, we're stretching in one plane of motion. We're doing our hamstring stretch. We're doing our quad stretch. So the fact that we're stretching is good. If we only stretch one plane of motion, then when our body requires us to go into those other dimensions or those other planes of motion, if that's not available, that's when an injury happens or that's when we're at risk. And so all of these assessments are identifying all 3 planes of motion because, you know, coming straight from the ground and picking something up or coming here and taking med boxes straight off, like that's not an issue. The issue is if I have to rotate and pick up here and come back this way. If that motion doesn't exist, then that's where the injury happens. And so all of these, I just wanted to clarify, like we have to assess all 3 planes of motion, and you guys are probably mobile in 1 or 2 of the planes, but it's that 3rd dimension that we're going to have to work on.
Totally. And we'll talk a little bit more about the real life application, but the one we joke about the most is the banister with the carry-all. Here you are, you have 4 people that can all deadlift 300 pounds or more, and you have a patient that weighs 200 pounds, and you have to walk them down the stairs, and you get in the spot where one guy's on the landing, somebody's at the feet, someone's at the head, you're reaching. It's those long levers, asymmetrical forces. Those are the high-risk ones. So, Edgar, I'm going to have you hop on the table here. Lay on your side for me, and you're going to face toward the camera. Chief, how does that look? We're in a good spot there? Okay. First rule, lock the table. You fail your exams in PT school if you don't lock the table. Okay, slide your butt back toward me a little bit. So this next one we're going to do, this is Bretzel stretch. So the guy that is kind of become famous for this, I don't think he gets all of the, you relax there, no cheating. I know you know the answers. The guy that's responsible for this, his name is Brett, and you look like a pretzel. So just don't overthink it, but it's called the Bretzel stretch. So starting position is we're going to have an individual lay on their side, and hopefully you guys can, you can take notes. We're going to send some videos out of all these too that you can test at home. But the first position is the top leg's going to come to a 90 degree at the chest, and the bottom hand's going to block that knee into the table. The second movement is that the bottom leg is going to come back, and we're going to grab our shoelaces here. Now, in this position, I'm going to give you a little cheat. If you look at the position he's in from a bird's eye view right now, you see his knee is forward, his knee is back. We just saw the exact same position. We just saw that this is the same thing as rotation of couch, right? The difference is that we have some different gravitational loads, and we have different muscles that are going to be active and different muscles that are going to be relaxed. This one's going to emphasize, well, and quite frankly, you can find the emphasis that you want on this one, but it's a great test to see, do I have appropriate mobility? What I love is that the table creates a rigidity or a block that you can't side bend out of this. It's going to keep you where you want to be. The assessment is, the test for home is if you can keep this knee on the table, and if we can get this shoulder, in an ideal world, we want to get it to the ground. In a passable, functional world, we want to get to about 60 or 70 degrees, and that would usually look like maybe 3 or 4 inches off the ground. So, Edgar, tight there, right? Yeah. This rotational load, we find that his quad right here is actually a huge limit. So watch this. We let go of the quad, and now what happens to the shoulder? Motion improves. So are you telling me that your right quad mobility has something to do with your left shoulder positioning in real life? Absolutely. And we'll throw an image up here in just a second about, it's called surape, S-U-R-A-P-E. It's the Spanish word for shawl. If you think about a shawl or a scarf going around somebody, it's how do we connect the diagonals, like Austin was talking about, these multiple planes in functional movement, especially lifting from the ground. So this is the assessment. This is also the correction. For correctives, what we love on this one is if you grab that shoelace, if Edgar pushes his shoelaces into this hand, almost like he's trying to kick a soccer ball, he's going to contract that muscle that we're trying to stretch, and then he's going to relax, and he's going to pull that heel toward his butt. And then he's going to push into his hand again. And what this is doing is the contraction is actually lengthening the quad muscle, and then when he relaxes, he takes up the slack. This is called PNF stretching. Okay, so this is a great technique for getting some mobility. The second one we can also do is that he can push his top leg into his right hand. So go ahead and push down and then relax. And what you'll feel is that when you exhale and relax, you can then create a little more trunk rotation. So push the thigh into the right hand and then relax, exhale. Now here we are improving just in the exact moment. We won't get too deep into this. A lot of times immobility is connected to the fact that a tissue is not long enough, right? But it's also extremely common that the muscle is under they call it hypertonicity. It's under a neurological tension or load because of the lack of confidence in that future position that you're trying to achieve. So this ability to create load and relax actually downregulates the nervous system and allows the body. Yoga, I'm not sure if they know what they're doing neurologically, but the breath work, bar, these things where they're really aware of how much you're breathing, when you breathe, how you breathe, it's all getting into some of that neurological solution to the mobility problem. Got it? Okay, so this is our first one. This is Bretzel. Now, let's keep you on for Bretzel 2 as well. Go up on hands and knees for me. If you guys have any questions on Bretzel or couch, go ahead and put them on the comments there, and we're happy to answer any questions.
Hey, Brad, real quick, if
Yes.
you have a hard time reaching your shoelaces, because your quads are so tight,
Love it.
grab a towel or something, loop it around your ankle and grab onto the towel.
Yeah, if you're in a gym setting, you've got the loop bands, like a pull-up band, a strap of any sort, like I said, towel, anything like that that allows you to basically make your arms 6 inches longer to reach that is great. So yeah, Caesar, any questions out there? Okay.
No.
All right. So the first one we talked about was couch. Second one was Bretzel. This one is now called Bretzel 2, and you're going to find that there's a strong similarity, each of them having a slight nuance in what they're going to offer you. But Edgar, you're going to sit on your left hip like you're riding side saddle on a horse. Perfect. So this leg's going to come across. The starting position, if you see his femur is pretty perpendicular here, we want this leg to be coming across. To me, the side saddle imagery, I don't know if that makes sense to anybody else, but if your torso is facing forward and your legs are facing sideways, we want this to be perpendicular. Now, there's a stretch that we love that is not this one called pigeon pose. Pigeon pose is when you bring your knee up between your hands. That is not the one that we're going for, at least not right now. So sometimes the starting position can be a little befuddling. The next thing we're going to do with these hands is you see Edgar's getting in this nice tall extension position. He's going to have about 70 or 80% of his weight is going to be on his left hand. Those of you who are doing it in person, you'll notice that the right hand can lift up no problem. The left hand, it's not an option, right? We'd have to totally deload it. So what you'll find is whichever hand is stuck, we're going to rotate to that direction. So now you look, we kind of get another dimension of this trunk flexion, hip mobility with some rotation. But this is a phenomenal one for getting tissue to lengthen. This is another one, Edgar, breath work, getting that diaphragm. So deep breath in. And then exhale and load into that stretch. That's a great one. Okay, so this is the assessment and it's the intervention, right? So this is Bretzel. Now, variations that we love, and we're going to send this all out in a video series you guys can watch on YouTube because there are some steps to it. Once you learn the steps, we tell people, we give you the groceries, you decide how and what you're going to eat, right? We'll give you the movements, and then you'll say, hey, depending on how I'm feeling or what I've done recently, this is what I'm going to do with it. So next we're going to go elbows to the mat. Elbows down. Great. Now, this is now introducing lumbar flexion. This is going to lengthen that posterior chain. Anyone who has a lot of tightness after you've been standing on say you've been on med call, you're working the iPad, you've just a lot of standing, especially in boots, you'll notice that you get that tightness in the low back and the belly kind of wants to come out. This is a great one for opening up the low back. Second variation to this is you then take the right hand and you're going to reach up. So remember, his left elbow is stuck in the table. It can't go anywhere. So if you're wondering, which arm do I reach with? You'll just know that one doesn't move. And the arm that is able to reach, that's the one you're going to reach with. A great cue for this one is you're going to put your right armpit toward the ground. And now we're creating that, like we talked about wringing out the towel, we're going to create torsion or mechanical rotation between the hips and the shoulders. So this is addressing all of those lower cross tissues that are getting us locked, right? So this is Bretzel 2. One you won't see from this view, but if he straightens out his leg, go back up to hands, Edgar. If he straightens out this leg, we can now get some hamstring IT stretch on this bottom leg as well. And that's another great variation. But all of these fit under that whole overarching principle or series of stretch movements, not muscles. You may feel it in your obliques, serratus anterior ribs one day. You may do it again another day and say, do this all in my glutes. But we're not so much concerned about where we're trying to feel it, but more as we create the shape the body needs, what is it that's being most restricted? Another question people will ask about pain. Should I stretch if I'm in pain? Or how much should I stretch? I'd say the biggest, maybe the overarching principle to it all is just remember what your purpose is to the intervention that you're applying. So if you're doing this and you're saying, hey, it's pre-workout, it's pre-call, and I'm feeling stiff, my objective is to stretch to become more mobile. I want to create the shapes and movements that I need. If you've been on a call, or maybe you lifted heavy the day before, you got a little tweak, a little bump and bruise, the back's sore, you're then going to stretch in order to decrease pain and increase confidence level in movement patterns. So how much should you stretch? However much you need with the intensity and the duration. But 9 times out of 10, you should always err on the side of low intensity and long duration stretching. We tell people, cook it in the smoker, not in the microwave. Your stretches should be low heat. long duration. Don't zap it. Don't 30-second nuke it, right? Low duration, long intensity. Or sorry, low intensity, long duration. Get up in the morning, check your emails, get in these positions, get that phone going, listen to a podcast, listen to your audiobook, but get in these positions to sit in this position for 5-10 minutes at a time to try and get more tissue elasticity to downregulate the nervous system. Those things are all extremely beneficial. So, questions on this one?
No, sir.
Okay, so this is Bretzel 2.
We've got a couple slides to show that serape.
Oh yeah, let's do it. Okay, you're good. Okay, let's cut to the image here. If you guys just kind of look at that right lat, so this is a posterior view here. You can see the right lat and the left glute, that rotational connection. Imagine somebody throwing a baseball or throwing a punch or swinging an object, a paddle or a bat. What you're going to see is that we step with our left and we swing with our right, or vice versa. But this serape connection, this is how we generate force and rotation. The lifting that we're now going to get into, we're going to get into some biomechanics, and this is probably going to be one of the most applied or most important parts of this, is that these connections are going to be the way that we stabilize our spine. If you are over a patient in the middle of the road performing emergency medical services, right? You don't have the chance to create the ergonomics or the positioning that your body needs or wants to be in. So knowing that some of these things are going to prepare you to do things that your body's not designed to do, that's the entire idea of this. I worked in a hospital for 13 years, and I remember running codes. You go into the room, you got this perfectly flat bed. You've got control of your environment and situation, and maybe there's a relative in the corner asking questions, and I would remember being like so annoyed. I'm like, hey, I'm doing my job. And I just think about what you guys do of going on calls in people's homes with debris and furniture and substances and individuals and just a lack of control. But being in society where you have so little control over how of what environment you're providing your services as a medic, like I have a ton of respect for that, but also knowing that it is not ideal. And in order to prepare for something that you shouldn't do, there's a lot of investment that needs to go in on the front end. So Austin, do you want to go through the hierarchy real quick, and then we'll do the PVC biomechanics?
I do, yeah.
Okay.
So this next slide, I just want to make a quick note about the idea of mobility versus stability. And this is kind of like, this is a trade secret, and I want you guys to know about it. You guys, sometimes we stretch so we can get more mobility, but if you've ever like stretched your hamstrings and you're doing it every single day and you just don't seem to have any progress, right? You stretch it and it's like Groundhog's Day. You're not making any progress on that mobility. Sometimes your body will disguise a mobility problem, a stability problem as a mobility problem. I'll say that one more time. Sometimes your bodies will disguise a stability problem as a mobility problem, meaning it tightens things down because it doesn't trust that it can control the movement. So rather than saying I have tight hamstrings or I'm unable to control motion with my spine, I just tighten down my hamstrings because everything connected to it is going to lock it down. And one of the best examples that I have of this is there's several times where we'll have people come in, they bend down, and they're like, I've never been able to touch my toes. I get here, and this is as far as I can go, and I just feel it right in the back of my legs. And I'll do a couple tests with them, and then we'll do some abdominal activation exercises. And within 2 to 3 minutes, they go from touching their knees or their shins to almost touching their shoelaces. We do some more, and then they get down and they can touch their toes. We never touch the hamstrings, we never stretch, but it's just the idea that sometimes your body will mask a stability issue with a mobility issue. So if you're stretching and you're just not making any progress and you still seem to tighten up, it might be one of those things. And if that's the case, then talk to one of the HFIs, give us a call, and we can run you through a quick screen and give you some things to do so we can reverse that. All right, let's go to the performance pyramid. One of the important things for everybody to understand is there's a hierarchy of how your body should move. Now, many times, we'll just stick with this pyramid. The foundation of any healthy lifestyle or movement program is to have mobility as the foundation. The next layer on that pyramid is stability. You have to have motion, and then you have to be able to control that motion. The third layer is strength. We need to be able to move stuff. And then the next layer is power. We have to move it quickly. And then the pinnacle is performance, whether that's a sport or a specific job task. So in order to have a healthy, consistent, powerful ability to complete tasks, whether it's a job or a sport, the least likely to get injured is if you follow this pathway, this program. Now, the way people typically run it is it's kind of inverted to where we'll go to the gym and we need to get stronger. Why do we need to get stronger? Because we're trying to improve our job performance. So we put the foundation of our fitness or exercise program in strength and performance, and then power and stability and mobility take a backseat. And you can see just by the infographic that you can survive on this for a little while, but the foundation isn't as good and it's a little risky to where you can get strong, and as soon as you start to become more powerful, you realize that you don't have the mobility or stability that you need to perform that task, and then an injury comes in, or your body will turn on the check engine light and say, hey, you need to look at something because something's not right. So before we get into anything else, we just wanted to talk about the importance of having enough motion first, and then being able to control the motion. And then once you can control it, then we get stronger and then more powerful, and then more job-related or sport-related tasks. You want 2 or 3 guys to come in for this part?
Let's just keep it in the camera view. Let's just do Brian.
Okay.
Just this very good-looking man. We're going to do PVC biomechanics?
Yeah, PVC biomechanics.
Okay. Let me see what the next slide is. Okay. Yeah, this will be perfect. Let's go PVC and then we'll wrap it up. So there's a third part to this, and we talk about the ability to have something that moves properly and then to be able to control it. The strengthening and power aspect to this is something that's going to come with exposure and time. If you guys know anything about periodization, how is it that we develop hypertrophy and activation of muscles? But what we want to close with is just getting into this performance part, which we could also call biomechanics, the ability to do your job properly. So, Brian, what I'm having you do is face toward the clock for me. We talked about that neutral spine. So what we're going to start with here is we're just going to put a PVC pipe here, and we want to see 3 points of contact: the back of Brian's head, his shoulder blades, and his tailbone. He's going to take the back of his right hand, and actually, Brian, go on the back here, outside, and I'm going to have you pin it against. Perfect, just like that. Now, the top hand's going to block from the top of the head. Now, this PVC is going to represent neutral spine. Your spine should have curvature, right? This little space in the neck, this little space in the low back. That curve of the spine is ideal and it's wanted. But what we want to show is that in lifting, it's super important that we make sure that we're using the mobility and the stability structures the way that they're designed for. So, Brian, if you'll turn this way for me. The first move we're going to do is keeping the knees locked. I'm going to have you hinge forward just at your hips. Good. And then back up tall. And then hinge forward. Good. Now, as you create that hinging motion with the knees locked, what do you feel?
Like slight stretch in the hamstrings.
Right? And so hamstrings are creating stability. They start to contract because if they don't activate, either he's going to go to the ground, right? So we're creating stability, but to you it feels like, oh, I'm not mobile enough, right? So the hamstrings are restricting the movement while keeping the spine neutral. Now, stand tall again for me. The next time, now we're going to incorporate a hinge. So when the hips move, we call that a hinge. We're then going to add a knee bend on top of that. So now I want you to hinge and then bend your knees, and now unbend your knees and unhinge. You feel it's kind of, they're 2 separate movements, and for now we're going to keep them separate. So hinge and bend and unbend and unhinge. Perfect. So what we're depicting here is that your ability to change elevation in your job, whether you're going down to grab a med box, or you're getting on the ground to work with a patient, or you're, like we talked about, the carry all, the transfer, the, getting somebody on the gurney, All of those movements are all about getting something to change elevation and then return. That's the definition of lifting, right? So what we're showing here is the two primary movements that we want to see are a hinge first. Now unlock those knees just a little bit. Now that hamstring tension goes away, and look, you can hinge further, right? We keep all 3 points of contact. Now, I know you would never do this in your life, Brian, but now show us poor posture. Flex that spine, right? So that's the arch, that's the excessive backward movement. Now show us forward where the PVC comes off, right? This flexion here, this is, I think most people look at this and they say, that does not look right. They know that that's dangerous, right? So I'm going to come back to neutral. But these movements of hip hinge and knee bend, when you put those together, that is lifting mechanics. That is a squat, right? Okay, go ahead and rest there. So Brian, I'm going to step back here real quick. Join me back here. So if we can just draw a quick stick figure here. Sorry, I made your head kind of big. Sorry. What we have here is a knee angle, and what we have here is a hip angle. Can you see my guy? You're picking up something from the ground. In this position, you'll look at, this is about a 90 degree and about a 90 degree. We call this a 50-50 position. 50% knee movement, 50% hip movement. Now, when you bend your knees, what muscle is going to activate? That's a quad activation. In the rehab or the performance world, they call that an anterior chain, right? If we bend at our hips, what muscles are going to activate? Glutes, hams, right? So this 50-50 position is based on the angle of both of those joints. Now, there's a different variation where we can go 20% knees, 80% hip. So this movement in the fitness world, what would you guys call that? A deadlift, right? Some people call it an RDL. There's lots of different names for it, Jefferson. But bottom line is that this is going to be primarily glute and hamstring. This is only going to be a little bit of quad. Now, question. What is the ideal ratio to lift from the ground, whether it's patient or equipment? What is the ideal ratio of knee to hip movement? The answer is slightly less than this in a 70-30 ratio. You want to be a primary posterior chain mover. The number one issue that keeps people from moving this way is not confidence or strength. It's a preconceived notion that someone said to you one time, lift with your legs. And when you heard legs, what you thought they meant was knees. And that's not true. When we lift with our knees and we keep our bodies totally upright, it's not going to work. What's going to happen is those are the types of positions that put excessive load on the knee joint. And that's stuff like knee arthritis, meniscus tears. But we're excessively loading that. What we want to see is this primary glute activation is going to be that hip hinge. Two primary reasons that we want to be glute activated movers is number one, the glute generates more force than the quad, so we perform better. And number two is that the hip is a multi-plane ball and socket joint that preserves and allows rotation, so the patient's between the toilet and the tub, and you don't have that opportunity to create proper form. This is the time to say, okay, I need to rely on my hips to move in multiple planes of movement, not my spine and not my knee, because they're not designed for that. So this ratio of being a posterior chain mover, you want to prevent rotational injuries because the hips are designed for rotation. And number two, we're going to perform better because our glute is made for it. Now, what we just talked about and what we want to make sure that we preserve, you showed it really well, Brian. Can you see that one? This is now 40, 40, 20, right? We're creating this lumbar extension in order to contribute. But the PVC straightness of these movements, that's the number one priority. In order to prevent an injury, I taught a class to a bunch of high school girls lifting the other day, and I said, if you can keep proper form, you won't get injured, you just won't be able to move the weight. And they said, well, I'm not sure if this is safe weight, this might be too heavy. If you preserve the form, you can't get injured. It'll just be that you won't successfully create the movement. So this right here, this is that lordosis. This is the arching back. And this is one that I think a lot of people, in order to prevent this, right? So that's 40, 40, 20 in reverse. But what's happening is somebody says, okay, I've used all of that hip movement, right? Now I've added all of my knee movement and I'm still not down there. Why does a carry-all have straps on it? Because we want to begin the movement. Why does a kettlebell, why is it 8 inches above the ground? Why are the plates on an Olympic bar putting you at 8 to 9 inches off the ground? It's because we want to begin the movement not at the ground. That's a big ask for the human body, especially for Americans because we spend so much time sitting. Ultimately, the takeaway is these are the no-fly zone. That excessive extension or that excessive flexion, because the spine is designed to be a stability structure. Isometric planks, abdominal activation is designed to control the spine, but that means that we have to have the ability to create those shapes in our hips, and that's the lower cross syndrome. We also have to have that ability to control movement in our mid-back and our shoulder blades. So, big takeaways here. Number one, we want to be a primary posterior chain mover as we lift from the ground. And number two, we want to make sure that we avoid any extension or flexion of the spine, especially under load. Does that make sense?
Absolutely.
I know we've talked about this in our HFI training. Is there anything there that we've talked about or that we've missed that we need to emphasize? Okay. There's another overarching principle that's not a part of the lecture today because we're wrapping up. But there's a principle called anti-rotation training, those pull-off presses that we taught you guys. Ask your HFIs to teach you about the ability to then control load and rotation. All of this is about what's called the sagittal plane, the ability to move forward and backward. But when you have a patient that has a majority of their body mass above their waistline and maybe small legs, you go to lift and that mechanical load is not symmetrical. And so now all of a sudden you have the same need for neutrality and balance in both a side to side and in a rotational plane. We talked about the banister, right? Getting over, some awkward piece of furniture while you're carrying a patient. So, we'll go back to that overall principle of you've got 4 individuals that net deadlift 1,600 pounds. Yet you have a patient that weighs 200 pounds and it's a heavy load. It's a lot of work. The reasons being, it's not just the distribution of load, it's about the ability to create the shape that your body needs to be in. So the big takeaways, the big conclusions that we get to in all of this is, number one, let's check these tests for mobility, right? Can I create the shape that my body needs to be in? And if I can't, let's start with that. Let's intervene and let's start to correct the ability to have enough runway to create that shape. The ability to then create stability, strength, and power. These are all relatives, right? These are all things that, there's an exercise program, there's a fitness level that goes into these. But what we've talked about here in conclusion about performance is, can I then get my body to do what I'm asking it to do in the real life? High stress. You do not think about, and you should not think about your posture when you're doing your job. That should be something that you've trained and programmed to where you can just throw the fastball. You don't need to ask yourself, well, hold on, where's my foot? And, assess, that's great. Be aware of your body. But you'll notice that in the high pressure situations, you're not thinking about you, right? It's about somebody else. And quite frankly, the ability to develop that program into performance, it makes you more successful at your job. Austin, can we go back to our original slide of the 3 paradigms, the very beginning? And we'll just close with this. The ability to have a long-lasting, that bottom x-axis measurement there of longevity, the ability to do your job for a very long time is very much correlated with the ability to do it properly. The task of a 25-year career, being up in the night, having the stress exposures, having the mechanical loads on a body, a really big ask. And I hope that we, as much as anyone as healthcare providers, can appreciate that. That second dimension on the y-axis of performance, the ability to do your job better and more successfully and to perform at a higher level. There's so many people that are saying, hey, I don't deadlift anymore in the gym because it hurts my back. And to say, there's a lot of things that we could do to allow you to train the way that you want to train, but that maybe you're fearful of, or you're thinking, every time I try it, it makes it worse. But let's not blow away the smoke. Let's put out the fire, get to the origin of these imbalances or asymmetries. But the most important arrow in that paradigm for us is that quality of life. And what you'll find is as you secure longevity and you know that you feel safe at work, that you can do this job, you can provide for your families, you can find that lifestyle that brought you into this career to begin with a passion, right? And then you can start to do it really well. All of a sudden you start to find, hey, I can go home at night and I can turn it off. I can find that work home life balance. I'm not lacking sleep because I wake up with orthopedic issues, neck and shoulder and low back. But all of this goes together that at Fenix Physical Therapy, we work with people. And all of this is about people. This is about your guys' ability to help the members of our community, of which Austin and I are a part. Our little boys see your fire trucks driving around town and we love it. And they say, hey, there's our guys, you know, and that's a lot of fun for us. But we genuinely have an interest in this. So last thing that we'll close with, Austin, do you want to go over that stretching or just introduction for that?
A couple months ago, we went and did some training with all of the HFIs, and what they decided would be best for everybody is to have a greatest hits of mobility exercises that you can keep in your station gym. And so what we did is we created the Bretzel 2 stretch, the couch stretch, pigeon stretch, dowel stretch, and open book stretch that specifically address the lower cross and upper cross syndrome. There are pictures and then some cues, but there's also QR codes that if you want to get a more detailed instruction on the video, it'll link right to the video. So all of these, well, there should be one of these in each station in the gym. And if you misplaced it or you need another one, let us know. We have them and we can get it to you. But we want to make sure that you guys hit all three dimensions of that graph to where you can have a high level of performance and have a long career and have a high level of quality of life too. So if there's any questions, we'd be happy to take them. If not, we're grateful for the opportunity to do this training, and thanks for your time. Fade to black.